surgery. And today I'll be starting with, can I share my screen? Okay, let me know if you're able to see my screen.
Yes, we can.
All right. So today we'll be starting with the topic upper airway resistance, mother of all diseases. So I'm Vikas, bring you greetings from Mumbai. We believe that out of all the medical specialties, most important specialty is cardiology. Why? Because a person dies if the heart stops working for a few minutes. But in the next 1 hour, I'll make you believe that it is the ENT which is the most important specialty, because prevention is better than cure. What you treat in the heart actually can be prevented if we ENT surgeons can look into the nose and the throat a little better and treat these nose and throat issues so that they can prevent heart disease. Yes, I mean what I say. You can, as a ENT surgeon, you can prevent a lot of heart diseases from happening. Let's see how. So the missing pillar in health is the breath. It all starts there with the breath. If the breath is not perfect, all the problems of health start from breathing improperly. So what is the max time when maximum heart attacks do happen? Is it late night, early morning? Is it afternoon? Is it, late morning? Is it early evening? We all know that maximum heart attacks happen between, 2 a.m. and 9 a.m. Somebody is writing not audible. Am I not audible?
No, sir. You can go ahead, sir. You're audible. We'll take.
All right, all right. So maximum heart attacks happen between late night, early morning. And why? Nobody is actually fighting at that time. Nobody is, stressed with work at that time. They're actually stressed with work in the afternoon, in the, early afternoon, late afternoon, evenings. They're struggling. Why is somebody not getting heart attack then? Why when he's sleeping peacefully? So this is the slide from Cleveland Clinic. Complications of obstructive sleep apnea. First one is heart damage and heart failure, then arrhythmias, sudden cardiac death, daytime sleepiness leading to accidents, health conditions like type 2 diabetes and high blood pressure. These are the commonest ones. Others one, memory loss, depression, are more subtle. Anu is writing, we cannot see the screen. Is there any problem?
Sir, I request you don't get distracted, sir. I will handle it in background. Everything is fine. Some
Sure.
people just have connection issues. We'll handle them.
Understand. Take it. All right. So obstructive sleep apnea leads to a lot of issues. Anxiety, brain fog are the commonest. Depression, they are the commonest, and people do not even realize that this is happening because of sleep apnea. High blood pressure, heart failure, type 2 diabetes, impotence, obesity is a result of sleep apnea, not only a cause of sleep apnea, it's also a result of sleep apnea. So all these things are so very important and well proven now. I do not have to actually show you studies to prove, because there are tons and tons of them proving that OSA is the cause of blood pressure, diabetes, heart attacks, and stroke. The most important heart conditions and the brain conditions are commonly a result of obstructive sleep apnea. It's proven beyond doubt. The risk of stroke is increased 2 times, sudden cardiac death twice, cardiovascular mortality 5 times, and atrial fibrillation even after ablation 57% risk is increased. These are different studies. I'll not really go into details, but it is well proven that it happens. I'll actually make you understand how it happens, right? If you go into detail of system wise, neurocognitive, sleepiness, fatigue, depression, attention deficit, occupational accident, motor vehicular accident, cardiovascular, cardiac failure, blood pressure, coronary heart disease, atrial fibrillation, nocturnal death, stroke, metabolic diabetes mellitus, sexual dysfunction, obstetric also, preeclampsia, gestational hypertension, low birth weight, hyperbilirubinemia, overall mortality, cardiovascular and non-cardiovascular related, exacerbation of asthma in the lungs, COPD, GI complication, GERD, non-alcoholic fatty liver, and ICU transfer respiratory complication, blah, blah, blah. Everything happens because of this. How it leads to accidents. Person is sleeping on the wheels. Reaction time increases, and that is the leading cause of vehicular accidents. And our truck drivers, they're all, eating at irregular times. They're eating at dhabas and they're all fat. Now, how big is this problem? This is an estimate by a very, very reputed researcher, Atul Malhotra, and his team. And you can see approximately 1 billion people over the planet are suffering from sleep apnea. And if you see the numbers, 936 million in the age group of 30 to 69, that means productive age group, have mild to severe obstructive sleep apnea, and 425 million 30 to 69 have moderate to severe. And highest seen in China, followed by US, Brazil, and India. So this is the data of the world by a very, very reputed research group, 1 billion people across the world. This is our Indian data. This is by Abhishek Goyal from AIIMS Bhopal. Now see what they have done. It's a study done on 727 people, not patients, people who were healthy from the community, not from the hospital, not walking into the clinics. They were randomly selected from the community in Bhopal, and a level 1 PSG was performed on them. And see what they get. Healthy volunteers, they got an incidence of moderate to severe sleep apnea, not even mild sleep apnea, 32.5%. Moderate to severe. Mild was seen in more than 70%. Moderate to severe sleep apnea was seen in 32.5, one third of the population. What we are even talking about. So this is our own Indian population. One third of the population of this sample is suffering from moderate to severe obstructive sleep apnea. It's a big problem, right? So this is one of the largest study done in the world with level 1 PSG, and ICMR funded study. So it has to be absolutely correct. Every study has its own small issues, but majority. So now we believe that only obesity causes sleep apnea. Yes, obesity definitely causes sleep apnea because there is more oxygen demand. There'll be more air sucked in with more velocity because the person requires more air. And obviously with obesity, there'll be more fat in the neck. So the airway will become small and it will compress the airway further. But
मैं 155 किलो का हूँ और रात में मुझे कोई विशेष खर्राटे भी नहीं आते हैं और दिन में भी मैं बिल्कुल नहीं सोता हूँ, सुबह 5:30 बजे उठ जाता हूँ।
now this person is 155 kg. You can see he's obese by every standard in the world. And he's a priest. He sleeps at 11. He gets up at 5, 6 hours of sleep and is pretty fresh. He doesn't snore. So if obesity was the only reason of sleep apnea, then why this person would not have sleep apnea? Why this person would not snore? 155 kg and he doesn't snore.
I had a problem of sleep apnea for almost 7 to 8 years actually, but I didn't realize that I had this problem because I used to snore in the night, and I did this sleep apnea test the next day, and the results were not very good actually. I got up around 46 times in 1 hour's time, and my breathing stopped for 41 seconds as maximum, which was not really good actually.
So now this guy, BMI is only 24, but AHI is 46 and his maximum apnea time was 41 seconds. The problem was only in his nose. He had got a grossly deviated septum. You can actually see it from outside. Grossly deviated septum and a turbinate hypertrophy, that's it. His palate was a little long. We only performed his nose surgery. His AHI came down drastically. Obviously, he's not completely cured, but he became much better. So what I'm saying is that many people are not obese. There are many non-obese, normal-looking people in whose even the sleep study is normal. Even if you perform a sleep study, their sleep study will be normal. Still, they are snoring. They have morning fatigue. They have daytime sleepiness. They have irritability. They have loss of libido and decreased performance. So what are they? They are not case of obstructive sleep apnea. They're not a case of simple snoring as well. They're a case of upper airway resistance syndrome. As the name suggests, upper airway resistance syndrome. So there is resistance in the upper airway. The airway is smaller. Though they are not obese, but the airway is still smaller. That means this problem happens when there is a mismatch in the demand and the supply. If the demand is more, like in that 155-year-old guy, but the supply is also more, if the airway is pretty wide, if his throat is wide, if his nose is wide, if there's no obstruction in the nose and the throat, and his demand is more, he'll still not have sleep apnea. And in the other case, if the supply is less, even in a thin patient, even in a BMI 24, 23 patient, if the supply is less, that means if his airway is narrow, the nose is narrow, there's some obstruction in the nose, or his throat is narrow, tonsils are large, his epiglottis is, collapsing, or something there in the air passage. If the supply is hampered in a person whose demand is less, but the supply is even lesser, he will still have obstructive sleep apnea. So if there's a problem with the demand, if somebody's problem is only a weight issue, then what is the solution? Solution is weight reduction, or by conservative means, or by bariatric surgery. If the airway is normal, but the demand is more, that means if you see no obstruction in the nose, if you see no obstruction in the throat, the palate length is normal, tonsils are not enlarged, lingual tonsils are not there, only the weight is more, and because of that, if the person is having sleep apnea, you can't be operating on the nose or the throat. You have to, make sure that the patient is reducing weight or is going for a bariatric surgery. Now, if the supply is less, if there's a problem with the supply, if the channel of the supply is narrow, then you can perform surgery on that patient, open up that channel more, or you can provide a PAP therapy so that through that narrow channel, the person can still breathe. Now, the supply can be narrowed at the nose level when we call it static obstruction, or in the throat when we can call it a dynamic obstruction. So obviously, PAP will not work when the nose is blocked. The static obstruction, the PAP will not work. Then surgery is the best option. If the throat is blocked, that means if the soft palate is long, if the tongue is collapsing, then you can either do a surgery or you can treat it with the PAP therapy. So this slide is the most important slide of the whole thing that you need to understand, that you have to first determine if this patient's problem is because of a demand or because of less supply. So the mismatch is because of which factor? Is it more demand or because of lesser supply? Now, when a child is born, he's born to breathe well, he's born to sleep well. When he grows into a young adult, obviously he's again meant to sleep well. If some adult has slept for 6 to 8 hours, he should be absolutely fresh. Why should a person, even after waking up after 6 to 8 hours of sleep, be like this or like this? We simply blame it on the stress. Oh, you're stressed. You're taking too much of stress of work. Therefore, you're, tired. We have to look into what else can be the cause. We cannot simply blame it on stress and leave him like that. This person who's having pain here and there is always tired, and, seeking medical help, but nobody is helping him, just blaming it on his stress level. He has not slept well, because if he is not, the sleep is the best detox for the brain. If you sleep well, then only the brain will be relieved of the toxins which accumulate in the brain. Just like if you work too hard, there'll be lactic acid accumulated in your muscles. If you take rest, that lactic acid is washed out. Similarly, there's something called a glymphatic system in the brain, just like lymphatic system of the body, which washes away the toxins which are accumulated during wakefulness, the waste products. And when you sleep well, all these waste products are being taken away from the brain, and that's the detox of the brain. And if you do not sleep well, the first thing is the problem with the mood. From here, you go right here. You are first joyful, then happy, then relaxed, indifferent, confused, sad, anxious, and angry. So these are all stages. The first day you may be still okay. Second day you'll be still try to relax yourself. Then by the end of fifth or sixth day, you will definitely turn confused and sad. And by if it is a few months that you are not able to sleep well, you are bound to be angry at every stage. So this is your first thing which hampers if you do not sleep well because of any reason is the mood. Then second comes your memory, the speed of your thoughts, creativity, the attention, focus, flexibility, all those higher mental functions start getting affected next. Till this time, you are still able to do your basic mental functions, but your higher mental functions go for a toss, and that's the time when your whole life is disturbed. I'll not take you through this busy slide. This slide only tells you that sleep deprivation via different mechanisms, of which I'm not going into details, leads to formation of or release of cytokine and cytokine-like chemicals you can see in the lower part. So sleep deprivation leads to release of cytokine and cytokine-like chemicals in the body via different mechanisms, which I will definitely not take you into detail. But what is cytokine? Cytokine is the chemical which is released from all these cells, macrophages, lymphocytes, mast cell, fibroblast, endothelial cells, granulocyte, in response to what? In response to trauma. If somebody gets trauma, what gets released? Cytokines. What it leads to? Inflammation, swelling, redness, pain, warmth. All cardinal signs of inflammation are result of cytokine and cytokine-like chemicals, which are also released in the whole body through those cells when somebody has not slept. So there's a low-grade inflammation in the whole body if you're not slept well. Now you realize that when you go to a marriage, party, marriage in the family, you are there for 2, 3 nights, and you do not sleep well because you are talking with your cousins and late nights. And when you come back, what happens? Your whole body is aching. You are tired. Of people suffering from sleep apnea for a long, long time. The whole body is inflamed. So if somebody is sleeping with the mouth open and snoring, this is a good warning that he's not sleeping peacefully. He's actually sleeping badly. He's not sleeping peacefully. What is happening inside? He's sleeping. His breathing is not normal. His breathing is disturbed. So this is like sleeping like this, driving with the handbrakes on. So if you're trying to sleep with your breathing, which is hampered every second like a handbrake, then what will happen? Your car ultimately will get spoiled because the engine will get spoiled, the brakes will get spoiled. Similarly, your body also gets spoiled if you're unable to breathe well during your sleep. And it all starts in the childhood. We know that adenoid enlargement is so common in childhood. Tonsil enlargement is again so common that people do not even consider it a disease, a problem. Forget about surgery. They do not even treat it. And with special, mention, with all due respect to our pediatric friends, many of them do not even consider it's a problem. Sleeping with the open mouth of a child is not a problem according to them. We need to make them understand that when the tonsil and adenoids are grown beyond a point and the child cannot breathe through his nose, what happens to the soft palate and the hard palate? The hard palate, which is supposed to be like this, gradually turns into a high arch palate because the child has to breathe through his mouth. If the child has to breathe through his mouth, the palate has to go up, his mouth will remain open, and the whole maxillary growth is hampered. It develops into a high arched palate. And when high arch palate develops, now you see in the CT scan, this tongue is not sitting on the palate. So there's a decoupling of the tongue in the hard palate or the soft palate. You can see this bubble of air. This palate is becoming high arched and it's pushing the septum against what? Against the brain. Septum is there between the brain and the palate. When the palate goes up, the septum is bound to get pushed on one, at least one side, or maybe both the sides in a S-shaped manner. So this leads to a deviated septum. Very, very common problem. Half of the world has got a deviated septum. Why? Because mouth breathing has started in childhood. And when the septum deviates to one side, you can see the turbinate on the left and the right, turbinate on the right. The inferior turbinate hypertrophy is on the roomy side. That further blocks the passage. Now the patient is unable to breathe through his nose completely. And as he grows an adult, he is a complete mouth breather. Nose is not getting utilized. So the deviated septum develops. This is the normal septum, the deviated septum. When the deviated septum develops, the turbinate hypertrophy happens. And now the nose is completely blocked. Once the nose is not used, then the sinuses are not getting ventilated, right? So if the sinuses are not getting ventilated, they get inflamed, because if they're not getting ventilated, the sinus lining gets inflamed, and that leads to sinusitis. So most of the sinusitis is actually because of less use of the nose. Pure type 2 inflammatory reaction, when there's polyposis or a polypoidal formation, tissue formation, is a different disease altogether. It's an autoimmune disease, but immunity related issue. But this is a pure mechanical issue which leads to sinusitis. And we try to perform sinus surgery, which never gives result, because it's the nasal breathing that we have not addressed. If the nose is not breathing, if the mouth breathing has developed and the person is not using the nose, whatever you do to the septum, to the sinuses, it will not recover, right? So it has to start functioning normally. The nasal breathing has to be established. Now the nose is not working. The person is sleeping with the mouth open. What happens? When the person is sleeping with the mouth open, the tongue falls behind. When the tongue falls behind, there's a further blockage of the air passage, leading to now snoring and sleep apnea. This person at this stage is not having obstructive sleep apnea. He's in the early stages. He's around, say, 25, 30, 35. But he gets up with the very bad headache and confused status and sleep not being completed, body ache here and there. You do a sleep study at this stage, it will be normal. There'll be no oxygen desaturation. So obviously his sleep is disturbed, but his airway has not completely collapsed. So this situation is like if there's a mosquito in the room who is biting you every few minutes or seconds, is disturbing your sleep, but will it lead to your oxygen desaturation? No. So upper airway resistance situation is like the person is having a disturbed sleep because of his own breath, but it is not enough to cause a collapse of the airway completely, and therefore the person will not have oxygen desaturation. So this is the stage of upper airway resistance, but no frank sleep apnea. It will develop later on. So now from this stage, the person in this stage, you can see fights in the house, fight on the road rage, because the person is already irritable, and claustrophobia. He reaches his office. Claustrophobia is a very, very common problem associated with nose blocks. A person who's having difficulty in breathing and nose block also has claustrophobia. All these things will keep on happening, and that's upper airway resistance syndrome. It was described around 30 years back, 32 years back by Christian Gliminalt. Almost 50% of the population has some kind of deviated septum or turbinate hypertrophy. Now, this is a huge number we are talking about. Around 1/4 of the population has got allergy. If you combine these two, almost 2/3 of the population has got some kind of a disturbance in the nose. 40% of the males in their 40s, they do snore. And upper airway resistance is common in females as equal to males. So males develop more sleep apnea because their palates are longer, because their overall length of the soft airway is more. But the blockages in the airway, the nose issues, are almost equally common in females. So we cannot discount females. They're almost equally affected by the upper airway resistance syndrome, which is the initial part or initial stage of the whole gamut. So I had the fortune of meeting Dr. Guilleminal thrice. The last was in 2013, and after that we lost him in 2019. So he described how leptin, ghrelin levels of hormones are altered in sleep deprivation. So what is ghrelin? It is the hunger hormone. When you are hungry, this hormone is secreted more. When you are satisfied, then the leptin is secreted more. I'll not take you into any detail of this biochemical thing. I'll simply explain you in a way that once you are not sleeping well and you are tired, you tend to eat more because you are tired, you want more carbs. So you tend to eat more. And once you eat more, what happens? This food stimulates more insulin to form because you eat more carbs, you make more insulin. Insulin, more insulin resistance. More insulin resistance will lead to diabetes. Insulin will help this energy stored as fat, so you'll become more fatty. Once you are more fatty, you require more oxygen. Then you are feeling more tired, more hungry, you eat more, and this cycle continues. So not breathing well leads to insulin resistance and weight increase just by this mechanism. And as you increase in weight, what will happen? Your airway, which was only vibrating earlier, is now completely collapsed. You start developing obstructive sleep apnea. From snoring, you start developing through upper airway resistance. Now you are having a proper obstructive sleep apnea, right? Then when your airway is blocked, then what will happen? Your oxygen level will drop. Once your oxygen level will drop, then what will happen? Your arteries will start reacting. Once your arteries will start reacting, from normal you will turn to pre-hypertension and then frank hypertension because your artery is now reacting to low oxygen saturation. So now you develop hypertension and all the complications of hypertension. Long hypertension, you are taking one drug, two drug, three drug, nothing is working, and you are having all the problems of hypertension. Now, as we said earlier, your arteries are reacting and your insulin is, pushing your, lipid to get stored, energy to get stored in form of lipid. This lipid is also getting stored in the intima of the cardiac arteries, coronary arteries. So you develop coronary heart disease. So this is all a result. This does not develop like that. Therefore, people who breathe well, who exercise well and breathe well, they do not develop heart disease so easily. So now this whole spectrum, I'll try to make you understand in a simple way that a person, when he's 20-year-old, you hit him, you slap him, he'll slap you back. He will not think twice. This is like simple snoring. A person who's snoring, but he's not stressed, he gets up very fresh in the morning, is a simple snorer. Then when this person is around 40 years of age, when you hit him, he will not hit you back because he'll be scared that it will lead to a police case. So he will not react. He will not hit you back, but he will react. He will be, thinking about it. He'll go to the police. He'll make some complaints, do this. He'll try to see to it that you do not hit him again. So this is the stage of upper airway resistance syndrome. This person is not falling. If you hit him, he'll not hit you back, but he'll not fall also. That's the stage of upper airway resistance syndrome. When the same person becomes 50, 55, 60, and you hit him, he will fall, but he'll still get up. Because now his energy is lesser, so he'll fall for a while, but he'll still get up. So this is the stage of mild to moderate obstructive sleep apnea. And when the same person is 75, 80, if you hit him, he'll possibly will not be able to get up or it'll take a long, long time to get up. This is the stage of severe obstructive sleep apnea. So this is a spectrum from simple snoring when there's no, tiredness, the person is only snoring, to upper airway resistance syndrome. When the AHI is less than 5, the person is tired and the AHI is less than 5. To mild sleep apnea when the AHI is 5 to 15, moderate when the AHI is 15 to 30, and severe when the AHI is more than 30. So this is the whole spectrum. And the last one is obesity hypoventilation, when even in the awake stage, the person is retaining CO2. That's the obesity hypoventilation stage. That is one of the last stage, or you call it Pickwickian syndrome, like that. So this is the spectrum. Now, You have to decide. Your car is in a state of fall on a, on an incline. Will you hold it now? Will you control it now? Or will you let it speed up and you'll try to control it here? Obviously, the best is to control it here. When the person is having simple snoring, upper airway resistance syndrome, mild obstructive sleep apnea, moderate obstructive sleep apnea, and not when he is already having a very, very severe obstructive sleep apnea. Unfortunately, people come for treatment when they are having severe obstructive sleep apnea. Now, if you look at the recommendations, surgery is recommended for upper airway resistance syndrome and mild and moderate obstructive sleep apnea. CPAP is recommended for severe obstructive sleep apnea as the first choice because now it is little late. However, if the person does not tolerate CPAP, then you have to make him CPAP compliant and therefore you can still think about surgery. But the best test to do surgery is this. And this is what my take home for today is that people come to your clinics. People go to doctors with problems of nose. They go to the doctors, they complain of nose block, they complain of recurrent URTI, but we do not understand that nose block is such a big problem because the nose is blocked, the person is bound to sleep with the mouth open. When the mouth is closed, mandible goes down. When the person is sleeping, the mandible goes behind. It will take the hyoid back with itself. In this situation, the hyoid goes down, behind and down. And where is the base of the tongue attached? It's attached on the hyoid bone. So when the hyoid goes behind, the base of the tongue also goes behind. And this is like a domino. Nose block, everything will collapse. The tongue will also go behind and further block the airway. Now this is a dice. See, with the mouth closed, the person is able to breathe. With the mouth closed,
Only with mouth closed,
with mouth
mouth
open,
open,
everything collapses. With mouth
mouth
closed,
closed.
it opens up. So this is what is very, very important to understand that majority of the people, the airway is completely collapsed when the mouth is wide open and it opens up when the mouth is closed. So we have to do something to the nose. Now, worldwide, the commonest problem with people go to doctors, adults as well as kids, is sardi, khansi, nose block. Everybody goes to 60 to 70% of the patients in the clinics go for sardi, khansi and nose block. And what doctors do? Prescribe antibiotics, prescribe allergy tablets, right? Thinking it's flu. How many times can one get flu? Every 15 days? Nobody should be getting flu every 15 days if the immunity is normal. So for acute stage, this treatment is okay. If somebody is having fever, is having headache and full everything, it's fine. But what about frequent? If the person is having frequent cough and cold and still they are being prescribed antibiotics and anti-allergics, and then they go to their ENT doctors. But honestly speaking, even most of us, even I used to do the same around 20 years back when I joined ENT 25 years back. This is what even I used to do in 99, 2000. I was not primed. So nose issue, I would just look into the nose. If I do not see anything big, I would simply prescribe the patient a nasal spray and send him home, thinking everything is allergy, either infection or allergy. That's the problem. It's not like that. Patient is confused, the doctor is confused, and he stops going to doctors thinking that nothing is going to happen. So if the patient has not come back to us, does not mean that he's cured. Now, this is again a slide from Cleveland Clinic. Can you see the reason for sore throat? Sore throat, obviously bacterial infection, allergy, tonsillitis, reflux. See this, overuse of voice or irritants. Mouth breathing. Mouth breathing is a cause of sore throat. So if you give antibiotic, gargles, this, that, steroid, it's not going to solve the problem. If the problem is mouth breathing, you have to treat mouth breathing. And patients come to doctors with sore throat. What we give? Antibiotic, gargle, antihistaminic, allergic and painkillers. That's not going to solve. Obviously, allergy is very common. 1/3 and 1/4 of the problem is suffering from allergy, but almost half the population is also suffering from deviated septum. Half the population is having deviated septum, turbinate hypertrophy, some kind of concavolusa and blockage in the nose. Can we ignore that? Is it allergic rhinitis? Is it sinusitis? Is it deviated? It's $1 million question. very, very important thing to understand that what are we dealing with? Because complaint of the patient, long-term complaint are only 5 or 6: nose block, sneezing, watering from the nose, morning fatigue, headache, facial pain, postnasal drip. In some patient this is more, some patient that is more. But these are the only 5, 6 symptoms. And patient is asking some question, we are trying to give him some other answer. Patient is asking whether my symptom will be taken care of, how long will I require medicine, will it require a surgery, will I be cured? If not, then which problem will be cured? Will I require still some medicine, which will I require revision surgery? We don't answer all these questions. And what we do, we try to just explain the patient that, okay, we'll try this, we'll try that, because we do not even know the probable outcome of our treatment before advising. We all are actually, trying some fluke with the nasal symptom because we do not want to give more than 2 or 3 minutes to that patient. We simply want to write something and send it off. I'm very sorry, but this is a very common occurrence. So this is not the right thing to do. We need to predict the outcome. If we are advising a surgery, if we are advising a long-term medical treatment, what we do a CT scan. After trying maximum medical therapy, we do a CT scan, and then what we look at the enteroethmoidal artery, whether it is hanging or not. See, anatomical variations and dangerous area are a second stage. The aim of the CT scan first is to understand what we are dealing with. Is it a structural problem or allergic problem? Will the patient get result or not? And that is the first aim. And traditionally, we are doing the CT scan as a last resort. Okay, we tried everything. Now, if medicines have not worked, we'll do the surgery, whether it works or whether it does not work. We can't help. We are doing it as a last resort. So we are only making ourselves safe by looking at the anatomical variations. Now, that's not the correct approach. The aim of the CT scan in long-standing disease should be to differentiate structural problem versus allergic problem versus combined problem. Now, if there is an obstruction on the road, then the road can be cleared. So to differentiate between a type 2 eosinophil mediated allergic inflammation, which involves the ethmoids, versus a structural problem versus a simple IgE mediated allergy where the ethmoids are normal. So structure versus allergy, IgE or type 2 mediated immunity, allergic inflammation, and a combined problem. This should be the aim of the CT scan. And when it should be ordered. If the patient is having a problem of nose block and this and that for last 5 to 7 years, if he has come to you in acute stage, that means everything will be wet, all his ethmoids will be full. You cannot do a CT scan at that stage. Neither you can do a CT scan at this stage when the patient is already treated with the steroids, because everything will be dry. So we should do a CT scan in a stage when it is neither all wet or neither all dry. If you also do a serum IgE, you will get a clean picture of what the patient's problem is, whether it is a structural problem or allergic problem. In allergy, whether it is ethmoiditis or a simple serum IgE or a combined problem. So here comes the role of the in-clinic CT scan. 1/10 radiation, 6 by 6 feet space. It has changed my life completely, because my way of looking at patients, giving them some treatment at the stage 1. Now I do the CT scan first. If the patient has come in a chronic stage, I'll first do the CT scan and then decide on what is the problem. Now I can very well see ethmoiditis, which I could not see with the endoscope. I can very well see the thickness of the inferior turbinate, whether it is bone, whether it is soft tissue. I can see the pattern of the sinuses. I can see the thickness of the posterior part of the inferior turbinate. I can see adenoids. I don't have to push a scope in somebody's nose. So a CBCT, in-clinic CT, is a very, very good tool to assess your airway right from the anterior most point to the posterior most point. And you can actually see this is the adenoid in an adult. As you come forward, you can see the sphenoid is absolutely clear. You can see the ethmoids are absolutely clear. And you can see large concha bullosa on the left, huge DNS to the right, turbinate hypertrophy of the left inferior turbinate on the left, and almost no sinusitis. So this is a purely structural patient, right? And here what I wanted to show you, that this high deviated septum is below the frontal sinus. I'll use this point later on. So I'm just showing it to you here, that every single patient you'll see the high deviated septum, the thick part of the septum is always below the frontal sinus, and it is only the very thin part, cribriform plate, is below the cribriform plate. So now you classify this patient into a structural problem, allergic problem, which is further classified into type 2 eosinophilic inflammation or IgE mediated immunity, and a combined problem. And then you can decide if it is a structural problem, then you can cure this patient by surgery. If it is allergic problem, which is either type 2, then you have to do FES. If it is IgE mediated, then you have to treat IgE mediated allergy by spray or tablets. Or if it is combined, then you have to do both. So if it is blockage, which is causing the traffic jam, remove this blockage, make it straight, and the patient will be really, really happy. Clear the obstruction and you'll get a clear path. Because if you try to give this patient a CPAP, if he's having sleep apnea, if he's having snoring, if you try to give him CPAP, he will be just unable to tolerate, because CPAP will do something like this. And this is what is happening with most of the patients today. Without doing a scan, just by history, we say, okay, you have nothing in the nose, you try CPAP. And he doesn't tolerate CPAP, and then we leave him to die. So please have a look inside the nose, either by endoscope or CT scan. CT scan is preferable before prescribing this. And you'll be amazed to see that majority of these patients have got a deviated septum, turbinate hypertrophy, concha bullosa, and it's a straight problem. It's a RAM-like problem. This patient, you do surgery, blockage will be gone forever. He will not require another surgery in life. Off and on, he might still require some antihistamine or some nasal spray because his basic problem was structure. Now, I'll not deal with the structure of the nose and in the nasal surgery part, because it's not it for today. Only thing I say that the nasal valve area, this septum, we operate suboptimally. We need to remove more of septal cartilage. The SMR is not an outdated surgery. We all do septoplasty. I'll not waste too much of time here because there's another day, 1 full hour on septoplasty and turbinoplasty only, no surgery only. So I'll come to that. But what is important is that you have to get the high part of the deviated septum completely out, both high and low. As you see here, you have to completely get out. The turbinates also, again, I'll spend one entire day on the turbinate. We'll deal on the different parts of the inferior turbinate, how to deal with different parts of the inferior turbinate. On 1 full hour, we'll deal with that. What all new things are coming in turbinoplasty, how we can get a nose which remains open throughout life after the surgery. So this will be a topic for another day, but this is one of the most important roles of a ENT into performing. A regular ENT can do all these surgeries very easily, but can give a very, very nice airway to the patient. Now, if the problem is because of a traffic jam, which is only because of number of cars, and you see in the CT scan that the ethmoids are all involved, patchy involvement of all the ethmoids, this patient is a type 2 allergic inflammation, and you will require do surgery, because anyway, not only because of the nose, there will be post-nasal drip, which will lead to further, post-nasal drip leading to further blockage in the nasopharyngeal area, leading to more viscosity of the secretions, more surface tension, leading to further sleep apnea. And it's only a matter of time when this patient may develop frank polyposis. So both these patients are actually like ramen. They have 10 heads, ethmoids on all sides, and you have to do a complete disease clearance. All the ethmoids have to be removed, because only steroids will help this patient. There's no use of antihistamines. And steroid use, you can only give by nasal spray. You cannot give by oral route. And you have to remove the ethmoids completely. For this reason, you have to remove all the heads of the Ravan to kill it. You cannot do an incomplete job. So you might require to use navigation in cases where you are going near the frontal sinus area and the skull base. Obviously, you will not, many experts do not require navigation, but most of them actually will still need it in this area of frontal recess and near the skull base.
Zero,
Again, spend
that's the frontal
day
recess.
on this. This should be your result. Your whole skull base is completely visualized, complete clearance of polyposis and all the ethmoidal cells, subtotal removal of the middle turbinate and the superior turbinate. I'll deal it on that day. So now this is the slide. You can actually, if you want, you can take pictures of this. If the problem is only structural, where you see deviated septum, turbinate hypertrophy, but the IgE is normal and the ethmoids are clear, a simple septoplasty, turbinoplasty can solve the problem. If the problem is allergic, that means the ethmoids are patchy, IgE may or may not be raised, then you need to require a complete ethmoidectomy. If the ethmoids are normal but the IgE is raised, then you need to treat the patient. You'll not obviously operate him, but you'll put him on a nasal spray or antihistamines. Then there is a combined problem where you have a structural problem as well as the ethmoids are patchy or plus minus IgE is raised. Then you'll require septoplasty, turbinoplasty, you'll require FES, complete FES, and followed by nasal spray. And then you have a situation of non-allergic rhinitis when there is either no structural issue, no IgE raised, or ethmoids are also clear. Then you have to look into the causes of non-allergic rhinitis. So this is the algorithm that I have been following for the last 15 to 20 years. It has given great results. You can try it out. The adenoids, if at all you do surgery, again, I'll devote a complete day on the boundaries of adenoid surgery, because adenoid surgery is a very, very important aspect of every ENT's repertoire. And this is the paper. I'll deal with the
that it does
adenoids,
not dis-
the boundaries of the adenoids and where you have to reach, and all aspects of oral adenoids, oral surgery, nasal surgery. What is important is that if you clean up the nose is like static removal. Suppose if some old lady has come to you with wax and you try to do the audiogram, it will be faulty, right? Because the audiogram will show more deafness than what is actually there. And if you try to give her a hearing aid, it will be even more faulty because the hearing aid will still not work. So you have to remove wax. So once you remove wax, then the 30 decibel deafness will be relaxed by just wax removal. So therefore, simply removing the obstruction in the nose is like static obstruction being removed, nose and the nasopharynx, will improve the CPAP compliance at least. And if the CPAP, you have to use the CPAP, then you have to work on the dynamic obstruction. Dynamic obstruction is where in the soft palate, base tongue, and the epiglottis. This is the dynamic obstruction. The nose was the static obstruction. In the nose, there are 5 muscles: levator palati, tensor palati. I'll go devote a full day onto the palatal anatomy, palatal physiology, and the anatomy, how it works. But you see, when the air is flowing through a narrow tube, like pharynx, what it is governed by few laws of physics, Poiseuille's law and Bernoulli's phenomenon. So what is Poiseuille's law? Poiseuille's law states that when the fluid passes through a narrow channel, the velocity of the fluid is increased. That is Poiseuille's law. And Bernoulli phenomenon states that when the velocity of the fluid is increased, there is a sucking or negative pressure on this side walls. That is Bernoulli's phenomenon. I'm just muting my phone. So in our airway, the only part which can collapse is the pharynx, right? Because the trachea is not collapsible and the nose is not collapsible. Only the pharynx is collapsible. The pharynx is a collapsible tube which is in this position when the person is actually lying down and sleeping. So it's more prone to collapse. And it's not a perfectly circular tube. It's actually an elliptical tube. The AP diameter is less than the lateral diameter generally. So it's even more prone to collapse. Now, this is the tube I'm talking about. This is how it collapses. Now, when you are snoring, the tube is collapsing and opening, and when it is completely collapsing, it is the sleep apnea. So the balance of forces, the collapsing pressure minus the standing pressure, will decide whether the tube will collapse or not collapse. So unfortunately, the distending forces are very weak and they are very less in number. One is the tracheal tug. Because of the trachea, the palate is, the whole pharynx is pulled taut. And that is the reason many sleep apneics or the children with adenoids will sleep with the neck extended. They try to pull their pharynx taut by keeping the trachea tight. The other is the dilator muscle tone. Therefore, when the person is awake, the muscle tone is maintained. The person goes into type 2 sleep or the stage 2 sleep, the muscle tone is reduced. And in REM, the muscle tone is completely reduced. So this sleep apnea is most severe in REM sleep. Collapsing forces are very strong and too many in number: abnormal anatomy, mechanical forces, gravity, Bernoulli, surface adhesion, etc. So our pharynx is anyway prone to collapse. Now, this is what I said. Once it is collapsing, but collapsing incompletely, then it is snoring. Now, what is the difference between snoring and sleep apnea? When it is completely collapses. So how does it completely collapse? And when it completely collapses, what happens? So I will not again take you to Starling register model, which is the physical basis, physics of this. I will explain to you it in a very easy way that when a person tries to suck fluid with a very poor quality tube. If you try to take nariyal pani with a very poor quality tube and you suck hard, the tube collapses. And when you suck harder, it does not open. That is Starling register. That if you suck harder, instead of opening, it closes more. That is obstructive sleep apnea. So when the demand is more because of the obesity and the lung is trying to pull the air down, the pharynx closes and the diaphragm pulls it more, diaphragm and the lungs, but the pharynx does not open, it closes further. It will not open by itself, and that is sleep apnea. And then what you have to do, you have to push some air from the other side. So when this tube blocks, what you do, you just push some air and the tube opens. So that is what is the Starling register model. That once it is blocked by this, if you push some, it is not opening up. In spite of the diaphragm working, it's not opening up. And that is obstructive sleep apnea. But if you push a little air from the top, it will open up. And that is the principle of CPAP. So CPAP is not a bad device. It's a good device. But problem is that if the nose is blocked, many people cannot tolerate. Almost 2/3 of the people do not use CPAP in spite of buying it. So we cannot just put CPAP and forget about it. So people who are not able to use CPAP, we have to treat them. See how CPAP works. Now, this is the sleep apnea. The pharynx is completely closed. Now, as you switch on the CPAP,
Switching the pharynx. Keeping the palate open. Switch off the CPAP.
as you switch off the CPAP, again, this is how the person is into apnea. This is how actually the CPAP works, right? But it will only work on the soft palate and it only gives a control. It will not give you a cure. So obviously we want to cure this patient. We cannot, give it to every patient and the patients who do not tolerate. So if the tonsils are large, again, I'll devote a whole day on the tonsils. If the tonsils are large, you will perform tonsillectomy. You'll do intracapsular tonsillectomy. I'll again not waste too much time on that today because there's again a whole day is dedicated to only tonsil surgery. All the aspects of tonsil surgery, extracapsular, intracapsular, painless, bloodless, how it works, how it does not work. The full day will be spent on tonsillectomy. So learning from our masters, Guilleminult, and now this CPAP, Kulin Suleiman, he was the person who invented CPAP. So last year we met him in Australia, our International Sleep Surgical Society conference in Australia, January 2024. We met him and we learned how he developed CPAP and what all difficulties, how he collaborated and what all difficulties he faced during development of the CPAP, how things were developed. And we were also doing the same thing. 2010, I was experimenting this, trying to figure out what is happening.
This is the apnea with the.
So then, during drug-induced sleep endoscopy, using BIS monitoring to do the correct staging and all, and developing models how actually sleep apnea happens. These were the models, different types of sleep endoscopy we used to perform. And then we, on 1,000 sleep endoscopy, research, we found out what are the movements which happen in the soft palate, how it goes behind, how it causes obstructive sleep apnea and snoring, what are the structures, how they meet. So as I said, there will be a full day dedicated to palatal movements and palatal surgery. Well, we'll be explaining all this in detail. What is the role of tonsillectomy, how the tonsil enlarges and causes sleep apnea. So we'll discuss everything on that day. right? And different muscles. So obviously this is going to be continued because my time is over now. 1 hour is over and we want to keep another 25-30 minutes for question and answers. So this is the first of the talks, and the rest of the topics, as Shrihars has already said. The second will be on DICE, when and how choosing the correct procedure, no surgery for obstructive sleep apnea and upper airway resistance, all about tonsillectomy, all about adenoidectomy, palate surgery for snoring and sleep apnea, which will also include the palate mechanisms, base tongue surgery, one on epiglottic surgery, one on skeletal surgery, assessment of result and managing our own failures, and the last one on PAP and the other methods of rehabilitation. So these all topics will cover in the forthcoming issues. And before I stop, I invite you all next year, 20th to 22nd of February 2026 to Bombay, where we are hosting the first International Sleep Surgical Society conference of our country, first time in our country, and one of the first in the Asian countries. And this is a very, very important meeting. You'll get more than 100 to 150 international faculty. The whole world important people from in this field will come. So please do register and join yourself in our International Sleep Surgical Society meeting in Bombay next year. And with this, I stop my presentation and I hand it over to Sri Harsha and you all for any questions that you might have. Thank
Sir,
you.
thank you, sir. So I will read out few questions which were posted in the chat section, sir.
Yeah.
So, Dr. R. Kumar, he is asking, is it necessary to do level 1 sleep study in all cases? I think you'll be talking about this topic.
Yeah, the detail I will be talking in one full talk, that which study to do and which not study to do. But shortly, it's not necessary to do sleep study level 1 in all cases. What is level 1? When you measure the brain waves. What is level 3? When you only do the cardiorespiratory monitoring. So when it is necessary to measure the brain waves, when you are not sure whether it is obstructive sleep apnea or not, if it is sleep talking, sleepwalking, central sleep apnea or not, or some other kind of sleep disorder, restless leg syndrome, then you have to measure the sleep waves from the brain. Then you have to do the level 1 sleep study. And if the patient is complicated, if the patient is having diabetes, blood pressure, heart disease, then you need to know accurately what is happening. You cannot be approximate. In level 3 is a approximate study. It gives all the parameters of the cardiopulmonary parameters, but not the brain parameters. So in these two situations, when you are not sure about the diagnosis and when it is a complicated patient with a lot of comorbidities, then you will do the level 1 study. Rest of the cases, you can go away with screening level 3 study, which is good enough for an approximate assessment of the patient.
Okay, next question by Dr. Sailesh. Is there any correlation between less percent of REM sleep and upper airway resistance syndrome?
Less percent of REM sleep. Can you repeat the question?
So is there any correlation between lesser percentage of REM in sleep and upper airway resistance syndrome?
So see, basically when the person has got an upper airway resistance syndrome, sleep goes through stage 1, stage 2, stage 3, stage 4, REM, and again stage 1, stage 2, stage 3, stage 4, or it can be stage REM followed by stage 2, stage 3, then again REM, like that. So it is a gradual progression of sleep. If the patient is not getting enough sleep to go into stage 2, stage 3, stage 4, he will never reach REM sleep most of the time. So upper airway resistance syndrome will definitely have a lesser REM sleep. So his refreshment will not happen, because refreshment happens during stage 3, stage 4 and REM sleep. So that will not happen. This REM is the sleep of the muscle relaxation, complete muscle relaxation. So it will never happen. So there is definite correlation of lesser REM sleep and upper airway resistance syndrome.
So second question, can we say upper airway resistance is secondary to sinonasal diseases in most of the patient?
Yes, 100%. though it is also because of tonsil enlargement, lingual tonsil enlargement, retrognathia, sometimes epiglottic problem, but nose is the commonest. So majority of the patients have upper airway resistance simply because of the nose. And that was my whole focus today. That nose surgery is what every ear surgeon is doing. If you only understand this problem and help the patient open up his nose, he'll be grateful to you for his life. And you will be saving a lot of persons and patients going into frank sleep apnea.
Okay. So third question, is there any role of sleep hygiene and or myofunctional therapy in upper airway resistance?
100%. See, as I said, you have to diagnose what is the problem. If the problem is a structural issue, only sleep hygiene cannot help. But if there's no structural issue and the patient is not sleeping well, he's not, sleep hygiene, his lights are on, he has taken a coffee before sleep, he's not getting enough, soundproof room, there are a lot of sounds coming, or there are mosquitoes in the room. So obviously sleep hygiene is very, very important. But if there's a problem with the deviated septum, how sleep hygiene will help? So we have to act on both.
So Dr. Shreya is asking, when do you advise adenoidectomy in adults?
Always. When not. If an adult has got adenoids, obviously, I'm not saying that if there are 5% or 10% adenoids in the roof of the nose, that's normal. But anybody having 25% onwards, 25, 30%, 50% of adenoids, the nasopharynx is the smallest area of the airway and surrounded by bony walls on three sides. There's only one, the anterior and the inferior walls are the only open. And the moment it goes and blocks the posterior choana, that cross-sectional area is the minimum. So the maximum impact of blockage is on the posterior choana. So you have to clear up the posterior choana completely and adenoidectomy. And then adenoid also give postnasal drip, which leads to, the whole nasopharynx is blocked because of that. So adenoidectomy in an adult having upper airway resistance syndrome or obstructive sleep apnea is a must in my view. You should never leave adenoids behind.
One more question by Dr. Kumar. Can we get level 3 done by home study by a company device? I think ResMed.
Yes, why not? Yes, why not? See, level 3 is basically a screening device which does a good job. I'm not against it at all. See, ours is a country of 140 crore population. And we all need, how many sleep labs can you create? It's impossible.
Yes.
And then logistic wise, manpower wise, so these devices are good, they're very good screening device. You should do it. And when needed, then you can go on to the level 1 or level 2 later on.
Technically, you don't even need a sleep technician for level 3.
No,
In
not
any,
at all. No.
any person, they can do it.
Absolutely.
Yes.
Absolutely.
So next question by Dr. Gabriela Zurita. Do you perform multi-level surgery for moderate to severe OSA? I think again, this is a very broad question.
But yeah, absolutely. So multi-level surgery for moderate to severe apnea is the commonest that I perform. Because in our country, people do not come to us mostly in upper airway resistance stage. Right? They come for some other problem, then we tell them that, okay, you also have this. Then he says, yeah, we also snore. But when they come with snoring, they come into a moderate and severe and very severe sleep apnea. So most of the patients that I operate, nose and the palate is the commonest. So that comes in multi-level. And most of the patients I operate are having AHI of 70, 80, 100. This is what we get. And they are all CPAP failures. So most of the patients that I operate are having AHI in the range of 30, 40, 50, 60, 70, 80 or 100.
So next question by Dr. Sonam Rati. At what age adenoidectomy to be advised, and what is your duration of medical management for these patients?
Yeah, so see, adenoid, at what age? Youngest I have performed is 14 months. But see, in the first 1 or 2 years of life, the adenoids are very soft. If you put them on good nasal spray and give some oral steroid intermittently, you can pull on time. So my criteria is that I would not jump on to do a surgery unless the child is having grade 3, grade 4 adenoids, first of all, grade 1, grade 2. Also, I'll be a little wary about operating. I'll put them on a nasal spray and watch. Grade 4, 100%. Grade 3, most of the times, I'll advise a surgery. I will first put them on good amount of oral and the nasal spray, steroid spray. If I can pull on time till the child is 10 kg weight, when it is good to get anesthesia, I'm happiest. But if the child is not responding, 3 months to 6 months, at the most I would wait. If the child is not responding, I will straight away do the adenoidectomy, because the anesthetists are great people. They do give very nice and safe anesthesia, and surgery has no complications, practically no complications. The small adenoids, they don't even bleed. Kids' adenoids are the easiest to treat. You treat them from the roots, they will never grow, they will not give you any trouble. And believe me, I would have done close to 1,000+ adenoidectomies till now. Adenoidectomy is the most satisfying surgery you can do in ENT. One of the most satisfying.
So another question again by Dr. Shailesh. So is upper airway resistance common in pediatric age group?
Extremely common. Extremely common. Tonsil adenoids are rampant, and some our population kids have some kind of retrognathia. Mouth breathing is never taken as a problem by the parents. They all believe that, okay, mouth breathing is okay, normal, having recurrent cold is normal. Let him breathe through his mouth. How does it matter? Sleep, the urination during sleep is okay. Kids do, nocturnal aneurysm is also not a problem. So it's very, very common, and you have to treat it in childhood. That's what my message is, that treat upper airway resistance in childhood. You will protect many patients from going into frank sleep apnea.
So do you follow any specific criteria to diagnose upper airway resistance?
We do not do a pediatric sleep study. It's very difficult. The study will most of the time come normal. There will no apneas as such. Even one apnea in a child is abnormal. So you will not get a 10-second apnea most of the time. But the history itself, that the child is having disturbed sleep, is walking, is moving on the bed, he's unable to sleep, well, he's not getting up fresh, he's irritable. That itself is good. But we may think about getting some objective criteria, not subjective. Yes, this suggestion is well taken.
So next question. In elderly snoring patients, what is your criteria to take a CT scan?
99%. When not to take a CT scan. So if I see that the septum is absolutely straight, the terminates are not hypertrophied at all, I can see through the, just a scope or my headlight, I can see through the nasopharynx, and there's no history of any cold, no history of any sinus disease, then maybe I'll not do a CT scan. Otherwise, I'll do a CBCT. Anyway, I do a CBCT to measure the length of the soft palate, to see the retroglossal space, everything. So I would do a CBCT anyways, nose and the throat. But for people, if you have absolutely no confusion that there's nothing in the nose, no complaints, you can see through everything very clear, then you may not do a CT scan. Otherwise, always do a CT scan, incomplete CT scan. Even till here, you should be seeing at the sagittal pictures as well.
Dr. Danya is asking, if a patient has high DNS and severe allergic rhinitis, do we need to address the septum?
100%. Tell me, if you have not addressed the high deviated septum, how the nasal spray will reach that side, right? The spray will not reach on that side if there is a high deviated septum. You have to deal with the high deviated septum for sure. Even if you want to give this patient, spray, and his airway is compromised, therefore his allergy is more. So it's not, it's not allergy only. Allergy is further compromised because of the airway, shape. If there is high deviated septum, the whole airway is not functioning properly. A streamline flow is not there, it's turbulent. Therefore, more allergens are depositing into the nose. So definitely you should correct the high deviated septum.
So Dr. Kumar has one more question. So he is asking, snoring patients, usually they don't get convinced for surgery when we diagnose. So how do you deal them?
Yeah, so see, first of all, Dr. Kumar, are you convinced on operating a patient? So my question, what used to happen with me earlier also, I used to advise a surgery. See, forget about snoring surgery, even a septoplasty. If I am convinced that yes, this patient will get a lifelong result, then only my voice and my eyes will tell that to the patient to get convinced. If I myself am not convinced, okay, I'll try my best, we'll see what happens. You may or may not get result. I'll try to correct it. So if you yourself are not sure, your patient can never get convinced. And you don't try to convince your patient. You try to convince yourself. Do you understand where is the problem? Are you sure of tackling it? My belief is that if I am convinced, I will say that, okay, I am convinced that you will get result. Now you go home, think about it. I need not convince you. You try everything else, come back. I'm convinced that I'll get you result. I'm very sure of getting you result. This is what is the problem is. I'll explain why I'm convinced, my points, and I'll give it in writing. That these are the points that I'm think, and I'll give it in writing. You take second, third opinions. You take your calls. I think that's the best way of convincing the patient. Don't try to convince. Convince yourself, and your patient will be convinced himself.
So there's one more question by Dr. Gaurav regarding turbinates. What is your role of turbinates, turbinoplasty, turbinate reduction? How do you deal whenever you see a large turbinates?
Yeah, so as I said, we'll have a complete session on the nose surgery, septoplasty, turbinoplasty. But in short, inferior turbinates, tell me, what is the commonest ENT medicine that people use? Otrivin, nose drop, or some kind of Nazivion, Otrivin, this, that. They work on the turbinates, right? Most commonly, the 200, 300 crore market, all the sprays are acting on the turbinates. Intranasal corticosteroid spray, they are acting majorly on the turbinates. So the turbinates you have to tackle. If there is a deviated septum, the turbinate is bound to be hypertrophy. There will be a bony component, there will be a soft tissue component. There is an upper part of the turbinate and lower part of the turbinate. The detail, I'll show you the thing in the next topic whenever it comes. But you have to do turbinoplasty. See, minimalistic turbinate reduction will not give you a lifelong result. You have to do a proper turbinoplasty. You cannot do a turbinectomy. You cannot remove the turbinate. You'll make the patient cripple. You have to do turbinoplasty. So 60 to 70% of the turbinate medial mucosa is preserved. 30 to 40% of the medial mucosa and the whole of lateral mucosa and the inferior mucosa, along with that part of the bone, is removed if the turbinate is hypertrophied in my practice. I use sonopet for the bone and coblation for the soft tissue, coblation debrider, whatever. So we'll deal with it in detail.
So Dr. Dinesh's question is, what is the role of septoplasty in pediatric patients when you operate on adenoids?
Very much, very much. If the septum is crooked sufficiently to cause airway obstruction, I correct it. Youngest I have done is a 4-year-old kid around 19 years back. Now the child is already an engineer. Nothing happens. So you have to understand that you have to do obviously minimal surgery in a small kid. The nose is growing. But anyway, you cannot wait for the nose shape. You cannot operate not for altering the nose shape. The whole face will change. Will become like this. Later on, the patient will not require a rhinoplasty, will require a maxillomandibular advancement. So it's criminal not to operate on pediatric septoplasty and let him have a disfigured face. See, 2-3 millimeter of nose, suppose if the nose does not grow well, I'll do a rhinoplasty. I'll send him to my rhinoplasty friend, when the child turns 19-20. But let him breathe well. That is how strongly I feel about it. And I do the same thing. 6 year, 7 year, 8 year, whatever part of the septum needs to be corrected. Obviously, I will not resect the whole septum in a small kid. Why should I? But I'll correct it to make sure that it does not obstruct.
So Dr. Bini is asking, after nasal septum surgery, also if person has tiredness and is using CPAP sometimes, what else is the next line of management?
Yeah, so we need to see if he's snoring and is tired, then obviously his palate could be long, his tonsils could be large, he could have lingual tonsils, he could have an epiglottic collapse. There could be other causes relating to the upper airway resistance itself. And then the patient could be a case of not upper airway resistance syndrome as such, but there could be, he could have problem with his sleep, like disturbed sleep because of some people have short, what you call, they get up very easily. With a little sound also they'll get up. So in those cases, we give them sedative pills in a very small doses, right? To improve their threshold for sleep, to increase their threshold.
Regarding patients on antidepressants and antipsychotics, which causes tongue relaxation, so
Yeah.
how do you manage these patients?
Very, very difficult. I remember a patient operating on a patient. I did a great surgery, nose and palate, wonderful surgery. But this patient was on antipsychotics and antidepressant for 5 to 7 years. His snoring improved, sleep apnea improved, but his mouth opening, he was a mouth breather since childhood. He still kept on mouth breathing, his tongue still kept on falling, and he could not come out of his antipsychotics. And he was 28 years of age, and he finally died because of sleep apnea, in spite of doing everything. Overdose of antipsychotics. I still remember that patient's face, right? I cannot name the surgeon who referred, and I discussed with him. So very, very bad. And this patient went on antipsychotics and antidepressants because of sleep apnea. So his whole life was spoiled from childhood, and by the age of 31, he was dead. I operated him at the age of 28. I'm talking of around 7 to 8 years back. So very, very important. Therefore, we should prevent the problem rather than letting them get into that stage.
So next question regarding polysomnography. I think you will be answering them in the next topic, but briefly I'll be asking the questions which were posted. So one is, can we do DICE directly without performing PSG? When do we do polysomnography?
No. Let me answer one by one.
Yeah.
Can you do DICE without doing polysomnography? The answer is, can you do impedance without doing audiogram? Do you do impedance without doing audiogram? No. So if the patient is not having a sleep apnea or a sleep disorder, and you're trying to figure out where is the obstruction for doing surgery, it doesn't make sense. Second, during DICE, you need to know what is the normal desaturation that the patient is used to during sleep, right? So how will you decide whether to go till the desaturation of 90, 80, 60, 70, unless you have not done a natural sleep study? So it's a strict no to do DICE without a sleep study before. You can do it in very, very rare circumstances, but not as a routine. Next question.
When do you do polysomnography?
So see, polysomnography, you can do the screening test to know whether the patient is suffering from sleep apnea or not, and 100% before doing a surgery. You cannot do a ear surgery without doing an audiogram, right? Cannot.
Yes.
Simply. So you cannot do a sleep surgery without doing a sleep study, for sure. And in every suspected sleep apnea, you obviously do at least a screening sleep study, if not level 1. Yeah.
Dr. Abhay Sharma is asking, do you commonly perform turbinate reduction in children?
Yes. Yes. Because see, children and adult, now children is up to 18, we call them children only. Na?
Hmm.
So pediatric population, as I said, it's not the age. In fact, more than septoplasty, you can do even a bigger amount of turbinate reduction in children. So if the bone of the turbinate is big, you can remove them with piezo, sonopet. You can remove the bone. If the soft tissue is large, you can remove them with coblation. You can do channeling, but obviously mouth breathing has to go away. Age doesn't matter at all.
So regarding adenoidectomy surgery, do you perform tonsillectomy even if they're grade 2 without any symptoms?
Yeah, so if I'm doing adenoidectomy and if I see that the tonsils are not large at all, I would still palpate and see whether grade 2, I'm deciding only on the tonsil which is spouting out, or it is still, there's a large tonsil inside the pillars. So sometimes there are endophytic tonsils. Large endophytic tonsils not seeing outside, I will do a tonsillectomy, or I'll do at least an intracapsular tonsillectomy. If they are not really large, no symptom, and I palpate and see that they are not even large inside the pillars, then why should I touch them? Absolutely no.
So then just a follow-up question for the previous. Why was the regarding one patient you were quoting who died at 30 years, why was he given antipsychotics for snoring in childhood?
No, because he could not sleep well, and he was put on these
Okay.
medicines thinking that he has a psychiatric. He did not have a psychiatric disorder, but he became addicted to since ages he was taking that. So he got addicted. He could not come out.
Next question by Dr. Binny. Use of oral appliance therapy. What is your opinion?
It's very important if the person is having mild to moderate sleep apnea, and there's no obvious nasal block, and if the tongue base is collapsing, the palate is not long. Obviously, you're not going to do a maxillomandibular advancement. You're not going to do a tongue base reduction or something. Then you try oral appliance and it works pretty well. But it depends on whether the patient can tolerate or not, because you can only, of the maximal, advancement, you can only go 50%. If you go do more, you'll have a TMJ problem. So it's not very, acceptable to everybody. But a properly made oral appliance can do wonders.
What about
Especially for
nasal splints?
sleep.
We see a lot of people sharing these Amazon links, nasal splints.
Yeah, so if somebody has a nasal valve issue,
Mm.
you put a splint, the matter will be solved.
Mm-hmm.
But it has to be only that.
Mm.
Rest of the things, how it cannot. So
Again,
everything is used in a particular situation.
Mhm. Dr. Gabriela is asking, what are your thoughts on maxillary expansion before septoplasty in kids and adults?
Yeah, so maxillary expansion is a very good tool, which actually, opens up the airway. The whole base is increased. As I said, that if the high palate arch develops, then the septum goes haywire. If you put it back like this, septum will not, you know. Unfortunately, in our country, it's not very commonly done. It's now getting started. So it's a very, very good tool when you do non-surgical maxillary expansion only in early childhood. Nothing like it. Perfect. When the child is already grown, then you have to do sarpe, marpe, and then open it up. If you see that the space is not that bad, and if the septoplasty is a much simpler surgery, right? And with turnoplasty, if the problem is less, you can do septoplasty, turnoplasty. If the maxilla is really narrow, then septoplasty, turnoplasty is not going to work. Then you have to do maxillary expansion, dome or marpe, sarpe, whatever.
So one commonly situation is after tonsillectomy and adenoidectomy, kids do still continue mouth breathing. So,
Yeah, because one of the reasons is the habit. Because they have been mouth breathing for ages, 6 to 8 years. Suddenly it will not go. Then you have to do myofunctional therapy, give them some, chin straps, and teach them, and then look at if there's another reason. If like this, if the maxilla is already narrow, whatever you do, you have to still expand it. So if all the factors are normal, then habit. If the factor is not corrected, then you have to correct the factor, and you have to retrain the muscles, myofunctional therapy.
Dr. Geetika is asking, could the patient on antipsychotics be saved by oral appliances to position the tongue forward?
Definitely, it can be tried. Why not? This is the best thing to do. But majority of the time, as I said, it's not easily tolerated unless really made well. And many patients cannot tolerate. 7 to 8 years back, honestly, I did not, get it made also. I could not even understand that in spite of doing a good surgery, still it will happen.
So next question by Dr. Abhay. Do you use any objective measures for nasal airflow like rhinomanometry, acoustic rhinometry?
Honestly, I tried it, but it didn't work so well. Objective measures didn't work so well in my hands. Having said that, they're very nice to have it and use it as a research tool. But most of the patients also, subjectively, they feel it more. And objectively, with the turbinate reduction, without turbinate reduction, you have to do it both ways. You can't just do it like that. And the stage that you do it in. So if you put them on a nasal spray, the flow will anyway improve. So there are various aspects to it. I do not have a great experience because in my practice, it didn't work out so well. But I'm open to it, and I believe it's a great tool to have it, especially for research purposes.
So next question, what are the findings in level 3 sleep study in upper airway resistance syndrome who doesn't have apneas?
So in level 3, you will not be able to make out upper airway resistance. In level 1, you will have the RERAs, respiratory effort related arousal, RERAs. So that will tell you that there are a lot of RERAs. AHI will be less, apnea, hypopnea will not happen, but there will be a lot of RERAs that you'll see in level 1 and level 2 study. You will not see RERAs in level 3 study. So that's the importance of doing level 1 study.
Dr. Solomon Krishnan is asking, do you perform SMR in children?
As I said, SMR is a detailed surgery, is an exhaustive surgery, is a big surgery. I'll definitely not perform SMR in a pediatric patient. I will do minimal excision. It's a growing nose. Obviously, I'll not remove the whole septum. But in an adult after the age of 18 to 20, I'll be not conservative. I'll do excision apart from the area which we'll discuss in our whole nose thing. This 2 points, anterior nasal spine and the area joining the upper lateral cartilage and the nasal septum. Behind that, everything goes away. Simply, a simple straight surgery will give you best result in every single case in an adult above the age of 18 to 20. In a pediatric age group, I will be very, very conservative, but I'll still do it wherever is the obstruction. If it is a bony obstruction, I'll use a piezo and remove it. No, I'll not remove the whole bone, but I'll remove the obstruction.
Yeah. So next question is, doc, can we combine turbinate surgery, UVPP, tonsillectomy, tongue surgery all at one time?
I would really, really be very, very careful in such patients. I will do it only in patients who have got a very simple, very small lymphoid base tongue. Once I'm packing the nose and doing a palate surgery, a large base tongue, I would never, 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 ever touch. Muscular base tongue, I would never, ever pack the nose and operate. If it is only a little bit of lymphoid tissue which I want to just coagulate, I will do it. But that's not really a tongue-based surgery, so to say. So most of the time, if the tongue is not large, then the nose and the palate together. If the tongue is large, then nose in one stage and the palate and tongue in one stage, because you are inflicting pain. So why inflicting pain twice? Palate and tongue both are painful. So give pain only once, and you put a nasal tube and do the palate and the tongue together in the second go or in the first go. In the same sitting, you do not block the nose because you want the patient to come out easily of anesthesia. If you block the nose, he'll have difficult time coming out of the anesthesia.
So can you comment about epiglotoplasty and arytenoidopexy for laryngeal OSA?
Yeah, so it's a wonderful surgery. Patients who have got epiglottic collapse, only primary epiglottic collapse, cannot even tolerate CPAP. And they are generally thin patients, generally. So a 7-minute surgery, to be precise, it doesn't take more than 5 to 7 minutes. You only coagulate the median glossoepiglottic ligament and create raw area on the base of the tongue and the epiglottic, the lingual surface of the epiglottis, and allow it to come closer. That's it. Wonderful surgery. I have stopped doing epiglotectomy almost completely. I've stopped last 7 to 8 years. I've stopped doing epiglotectomies. I'm doing only glossoepiglotopexy. Wonderful result. Everybody should learn.
Any thoughts on hyoid suspension for epiglottic collapse?
Honestly, Abhay, if it is epiglottic collapse, a glossoepiglotopexy is a much easier thing for me to do rather than taking an incision. This will give me a 5 millimeter at the most, right? When you stitch the epiglottis onto the thyroid cartilage, this gives you 4 to 5 millimeter, not more than that. Having said that, I'm not against it. But most of them, I'll do a glossoepiglotopexy where the patient can, go home the same day, eat. There'll be extubation on the table, by the evening discharge, ice creams by the evening. It's a much, much lesser procedure to perform than a hyoid suspension. However, I'm not against. If it is an obese patient and you do not want to do anything intraorally, and that's a difficult area, dangerous area actually to operate in, then you can definitely do that.
So what's your take on hypoglossal nerve stimulation?
I'm trying to bring it to India for the last so many years. So I have patients waiting for that. Hypoglossal nerve stimulation, people who have a collapsible tongue, not large tongue, collapsible tongue. What else can you do? Like this patient on antipsychotic drugs. Obviously, when he's on antipsychotic, he's not the right candidate for a hypoglossal nerve stimulation. But if it is a collapsible tongue because of any reason which is not large, which you cannot cut and make small, hypoglossal nerve stimulation is like, God. Though it is pretty costly and it's not available in India, I'm trying to bring it to India for so many years. I hope that I'll start at least doing it in Dubai. Dubai, it's available. My current visit, I'm right now sitting in Dubai, and I'm hoping that I should be able to do it ASAP.
So
Yeah.
that's all the questions from the chat section. So anybody who wish to ask questions can unmute and speak directly.
So I really thank everybody for being here for 1.5, and I think we have exceeded our time by 10 minutes already. But I'm very happy that I stopped in 1 hour and then we have half an hour question answer. Casey sir, any complication from epiglottoplexy? Yeah, so obviously if you go lateral to the midline and you damage the lateral glossoepiglottic ligament, the main arterial supply, which is a branch of the lingual, the lateral glossoepiglottic ligament has the artery, and you damage that artery, then it can bleed like crazy. And it will be really very difficult to save your patient. So you can kill the patient doing glottoepiglottoplexy in a very easy manner if you do not stick yourself to midline. Sometimes there are large vessels in the midline also. You have to really be very careful. Veins you can coagulate, but arteries you have to be really, really very careful. You should not damage any artery in the tongue base area.
Good evening, Vikas sir. Shailesh here.
Hi Shailesh, how are you?
How are you, sir? As
Interesting
usual, great
meeting you.
presentation, and hats off to you answering all Q&A for more than
You're
40
in Monterey,
minutes.
right? You're in
Yes,
Monterey
I'm in
today
Monterey.
also. Yeah.
Yes.
Hey, my hello to
I think your
Rodolfo.
Q&A is bigger than your presentation.
That's
So
most.
I always appreciate your patiently answer all the questions.
Yes, Shailesh. What is your
Thank you,
question?
sir. Thank you. Great presentation. See you in the next presentation again.
Thank you, Shailesh.
So, sir, I think that's all for the day. We'll conclude for today, and we will be sharing the exact dates and timings for the next webinar in all our WhatsApp and social media groups. So, thank you all for attending, and thank you, Dr. Vikas, sir.
One question in the end, sir.
Yeah.
May I have the copy of the webinar page of this video?
Yeah,
if
we will
possible?
make it available. We'll make it available.
Thank
Yeah.
you very much. Appreciate it. Thank you so much.
I thank you, Harsha and Kishore. I thank you both for proposing this and doing this. I believe it was a very, very good meeting and people enjoyed, and I also enjoyed, because in conferences you get 15-minute talk. There's so many things you cannot discuss in 15 minutes. That's the problem. So I believe that people will be able to learn and take this subject forward. And this subject is what can make ENT a really, really important specialty among all these surgical specialties. Thank you once again.
Thank you. Good night, everyone.
Good night.
Sir, just a small question.
Yeah.
You mentioned when you operate on the epiglottis, do these patients develop aspiration post-operative?
Not at all. See, epiglottectomy, when you remove the epiglottis,
Yes,
then
sir.
there's a temporary aspiration. If you
Yes.
remove the epiglottis completely, then only there is a question of aspiration. See, even that recovers in some point of time. You see, when we do surgery I was in Tata Memorial and we used to do a lot of base tongue excision and epiglottic surgeries for epiglottic carcinomas.
Right, sir.
See, ultimately, the base tongue compensates, right? Here we are doing only epiglottoplexy, only sticking it together. Nothing, not even a single day. Nothing.
Okay.
Absolutely not. Glossoepiglottoplexy, nothing will happen.
Okay. Thank you, sir.
Okay, sir. I think we'll conclude for the day. Thank you.
Yeah. Thank you. Because of want of time, we'll have to. Thank you very much.
Thank you.